Janet Elliott, and I'm a professor in the Faculty of Engineering and also in the Faculty of Medicine and Dentistry, and I've been affiliated with the Alberta Transplant Institute for some time. I'd like to start our seminar today by acknowledging that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd also like to thank our sponsors. Thank you to Paladin, Astellas, and AstraZeneca for their support of the ATI seminar series. And today we have two speakers talking about tissue transplantation. And I think we are going to start with Dr. Nadr Jomha. Dr. Nadr Jomha is a professor in the Department of Surgery at the University of Alberta. He's the Director of Orthopedic Research and Interim Divisional Director. He's an orthopedic surgeon with subspecialty training in lower extremity joint reconstruction and trauma and has performed over 10,000 operations in these areas. He also has a PhD in cryopreservation of articular cartilage for the purpose of transplantation, and his research is primarily focused on vitrification and regeneration of joint tissues such as articular cartilage and meniscus for the purpose of reconstructing joint defects in addition to development of talar bone replacement prosthesis. And he has over 100 publications in these areas. And today, Dr. Jomha will be presenting on osteochondral transplantation, how research leads to clinical practice. And if everyone can, we're gonna have two speakers and just hold your questions until after both speakers have had their chance. So go ahead, Dr. Jomha.
So I do have a patent on some of the research protocol that we'll mention very briefly in this, otherwise no conflicts. So our two objectives are stated here. Basically, I would like you to understand what osteochondral allografting is and when we use it and how this has led to clinical practice from our research. Osteochondral allografting is the transplantation of bone, which is the osteo, and joint cartilage, the chondral portion, from a donor patient, as opposed to autografting, which would be from the same patient. It can be joint cartilage alone, but then we would call it chondral allografting. I'll start with a brief case. This is a knee intraoperatively. The foot would be on the right of your screen and the thigh on the left. So we just have the knee incision. Not sure if you can see my mouse, but this would be the joint line. This is the tibia bone here and the femur bone. And these sutures here are holding the meniscus away from the cartilage, which is severely damaged. I have now taken out a portion of the tibial plateau, and this surface here should be white and glistening, and you can see it's basically severely degenerative and arthritic, and we have excised that. I'm distracting the joint here for the later implantation. So this is some tissue that would be supplied by the CTC, or Comprehensive Tissue Center. It's a proximal tibia. This is the articular surfaces of the tibia, which we will incorporate with a bone base. So I've taken my portion of the graft, articular cartilage here, bone base here. We'll insert it into that defect and put a plate on it to hold it in place until the bones can grow together. The probe is just at the junction of where the graft has been inserted. Again, the meniscus is just sitting on top of it as we would like it. We'll stitch that back down. And we can see an X-ray here where on the left side of the joint, we can see the transplanted osteochondral segment, partial joint transplant, we would call that. So that is an osteochondral transplant. So this is not a very common procedure, but part of that is due to the limitations of storage of osteochondral tissue. When we do this type of surgery, we'll need to size and contour match, because you don't want to have too big of a segment or the wrong shape going into a joint, because the joints run very precisely. We also need time for infectious disease testing, and we have to time the surgery. We don't know when the patients are going to present to us with these problems. Sometimes it can be a traumatic injury, sometimes it can be a chronic injury, and we need to also get operating time, and in the current healthcare environment, that can be extremely difficult. And there is a difficulty storing this tissue longer than 14 to 28 days, and sort out all of these issues within that time frame can be extremely difficult. So my research has focused on vitrification of joint tissues, primarily articular cartilage, but also meniscus. So vitrification is the cold preservation of biologic tissues at very low sub-zero temperatures in a water-based solution without ice crystal formation. Basically, we will take the tissues and place it in a water-based solution with some additives and cool it in a very specific way, which is what we have patented, to get the temperature down to minus 130 to minus 196 degrees Celsius in liquid nitrogen vapor or liquid itself. And we can store it there. And we have to do it in a specific manner to get the cartilage down to that temperature without ice forming, because ice will kill the cells and damage the matrix. Then we need to be able to warm it back up again without forming ice and without killing the cells and damaging the matrix. I consider this suspended animation because at those very low temperatures, there are no biologic reactions. So the cells that on that day that you cryopreserve them or vitrify them, when you warm them up, could be 1 day later, could be 100 years later, they're essentially the same age because nothing has happened to that cell during that time, and therefore we could consider this as indefinite storage. The second part of my research is the development of a talar bone implant. As you can see in this image here, this is one of the first ones that I put in. And there's actually been very few of these done in the world, and I would say less than probably 200 to 300. And you might wonder, oh, how does this have to do anything with CTC and with tissue transplant? And it's because of this research, it helps to develop a program that I made with the Comprehensive Tissue Center for osteochondral transplanting for the talus. So I'll explain that now. So when we do talar, so the talus bone is the ankle bone. So if we look back at this picture here, this is the side view on the right and the front view on the left. So that's your leg bone above it, your ankle bone called the talus, and then below it is your calcaneus. So the talus bone is the one that I'm going to talk about. So typically, as mentioned earlier, we would require size matching and contour matching for any osteochondral graft, and that's been the standard for many years. Osteochondral transplanting has been going on probably for about 50 years. But this can mean waiting many months to get the appropriate size. Typically, if I order one of these from the States, which is where the access has been before I worked with the CTC, I waited up to 20 months to get one. So the patient is wandering around on their injured limb for that period of time. And it can be very expensive, which we'll talk about later. And one of the tissue banks told me that they discard about 70% of their tissue because of lack of use, because of inappropriate size and contour matching. So during the research for my talar implant, what we would do is one of my engineering colleagues said to me, well, maybe all taluses are the same shape. And I'm like, well, that can't really be because everybody's different size and shape and weight and height. And he's like, well, let's just check it out. So we decided to take a lot of CT scans and take the talus bones and image them and overlay the 3D models that we created from each of these different patients. And what we would do is we would size them. So we would get their general shape, and then we would just enlarge it or shrink it so that the two sizes matched. And what we were looking was for shape matching, not size matching. And then we would overlay the two, as you can see on the image on the right, and we would get this deviation contour mapping. And it would show degrees of shape differences. So where there would be blue would be more of a match, and as it would get to red, it would be a little bit more of a defect, and the different colors would show the amount of difference. So we initially took 27 subjects, 27 different CTs, and we sized them all, and you can see the sizes here. And then we looked at their shape and we compared all of them to subject 28, which is in the middle there, our reference subject. And we just checked all of the sizes, all of the shapes, one to another once we had standardized the size. And when we did that, what we realized is that the vast majority of the areas of the talus matched within 1 millimeter of the reference talus, meaning that they were all extremely similar in shape, but we can see there is a variation in size. So you could take a single shape and you could scale it up or scale it down, and it would fit almost anybody's ankle joint. We have now extended this to over 100 or to 100 patients. We now have a range of 10 sizes that will fit all the patients. So what that told me was the talus is a very similar shape between people, and therefore their articular surface that we're going to transplant is going to be a very similar shape. But there is a size difference between, let's say, a small female and a large male. There's going to be a size difference. So we did another study with that thought in mind. And what we did was we took, again, more CT scans, and we did virtual sectioning of a portion of each of the CT scans. So we took 4 groups. We had large male group, medium male size group, a small size male group, and a small female group, so that we could get a very large range of sizes of taluses, knowing that they are very similar shape. And then we took sections, 20 millimeters and 30 millimeter sections from both the inside medial side and the outside or lateral side of the dome of the articular surface of the talus that we typically transplant, and we interchanged them between. So we took one from a large male and put it in another large male and put it into the third large male, and we again checked the contour deviation. And then we would take the large male from one and compare it to the medium male, the small male, and the small female, and to compare it to those to see how well the contour matched. And what we found was any 20 millimeter length of talar dome from any patient, male or female, would fit with any other patient, didn't matter what size they were, within a 1 millimeter tolerance. And therefore we concluded, and 20 millimeters is typically the size of osteochondral transplant we would use, we did not need to size match or sex match. And if we needed to go 30 millimeters, which is almost the whole length of the joint surface at the ankle joint, we only needed to sex match, because there was a little bit more difficulty matching the smallest female with the largest male. So I took that information and I took it to the CTC and I said, let's start a transplant program. Let's, because it's costing us between $6,500 and $8,500, and this was many years ago. I suspect that cost has gone up to get these in from the States, and often it takes many months. And I'm also a bit suspect of their quality of their tissue, because once I transplanted, I would send it back to the lab, and it always came back questionable good cell viability. So the CTC asked me to do some quality control. So what we did was they provided some talus bones from donors that consented for donors, and we split them. And so we had 6 taluses, and we put them in the storage solution. And every week we would take them out and we would measure the cell viability and the metabolic activity to make sure the cells were surviving. And so after 2 weeks, we noticed we still had excellent cell viability and excellent metabolic activity, but at 3 weeks, it dropped off significantly. So we came up with a plan where when I have a patient that needs a partial talar transplant, I notify the CTC which side, then we wait for the next donor. When the next donor comes, I make sure that the patient is available, that I can find an operating time for the patient, and then we do the transplant within 14 days to make sure that we have excellent cell viability. So this is how many that we've done in the last few years. Now, of course, COVID had some impact on our uptake, and also, as it was a trial at the beginning, things started a bit slow, but they're picking up now. And you can see we've extended this also to other joints. This process, and it's worked extremely well. And so my estimated cost savings for this, the CTC provided that it cost them approximately $400 to do one of these, whereas the costs that I was incurring when I did this and got these from the States were, as you see, the talus was about $7,000, $8,000, whereas the femoral condyle was up to $14,000. So the benefits of this program is that there's no tissue wastage. If I don't need it, they don't harvest it. If I need it, they'll harvest the one, and then I can use it, and it's pretty much guaranteed it's going to fit. Patients now have increased access. So as we roll this out, we're going to see more and more of this being used, because right now patients are just not getting treated. And the access is rapid. Typically, I'm going to get that within 1 or 2 months, as opposed to waiting 1 to 2 years. The tissue is healthy, we know from our research, and there's significant cost savings. Based on the 16 grafts done so far, I estimate that we have saved over $135,000 just by this program, while increasing patient access and results. So we also have plans for future collaboration. So that is fresh tissue. That's got to be done within 14 days. Again, there are some logistical problems. So our research is looking at vitrified joint cartilage. So the vitrified cartilage, as mentioned, can stay indefinitely. And we're looking at particulated graft, which is cartilage-only graft, and also osteochondral grafts. And this is where our primary research has been. So this image here is an arthroscopy of a knee joint. That's the femoral condyle at the top. The area is pointing to a defect in the cartilage. Underneath, you can see that's hard subchondral bone, and the white stuff is the articular cartilage, and that's fairly normal looking, except for at the back, it's a little bit rough. So this defect has been cleaned up, and it's ready for some kind of transplant. So a standard procedure, one of them, is to fill this with small chips of articular cartilage, and then secure that in there with a fibrin glue, allow those cells to migrate out of that and then form a new fibrocartilage, which is not normal cartilage, but it provides some reasonable resurfacing. So our vitrification protocol has been developed using pig articular cartilage, and then we confirm it with tissue supplied by the CTC for donors consented for research. So we do all our grunt work with the pigs, so to speak, because we have great access with one of the delis close by and one of the farmers close by to provide them. And it takes a lot of pig joints to figure out these things. And then once we have a protocol down, we confirm that it works on humans using tissue from the CTC. This was a pig transplant study we did. The image on the left has the little instrument pointing to this defect that we made in the cartilage. Then we fill this defect with vitrified chips and some fibrin glue, or else with fresh chips and fibrin glue. And then we get these pigs 6 months time to walk around on it, and we can see the defect is filled. Now, it's not a perfect repair. This could be partially due to 130 to 230 kilogram pigs walking around immediately after their surgery, whereas that we don't normally do that. It could be just due to the location, or it could be due to it not being normal cartilage. So this is a type of repair, and in this study, we can see the F is the fresh, the V is the vitrified, and N is the normal from the other side of the joint. And we can see that the vitrified and these two scoring systems, which are basically scoring what the cartilage looks like, show that the fresh and the vitrified are basically equivalent, which is what the surgery was attempted to show, because the standard of care currently is to use fresh, but we've now shown that vitrified is a viable option. And we plan to try to institute this in the CTC as well as across Canada. And also to note that this type of surgery, one donor from one femoral condyle can typically provide approximately 30 samples, and those 30 samples can then be used for 30 different patients for that defect. So the other portion of the research is to look at large osteochondral allografts, so partial joint replacements, such as I showed at the beginning. This is cartilage and bone defects and can be whole joint surfaces. I'm going to give you one example of what this can do for patients. Now, this is not a vitrified, this is a fresh sample. This young guy had this severe deformity in his femoral condyle in his knee. And on this image here, you can see the medial side is fairly normal. The lateral side is irregular and jagged, and you can see it's flattened here. CT scan is much better. You can see the bone is crumbly and there's no surface here, whereas on the medial side, there's a fairly normal surface, not completely normal. And this is the side view. This is his other knee, or the medial side, sorry, and you can see that normal joint surface, and that's his lateral side, and you can see it's completely flat, so it's obviously not going to work well. And this is what he walked like. He's 18 years old, worked in a butcher shop, and this is how he gets around. Basically, a fused knee. So this is intraoperatively. His thigh is on the right, his leg is down on the left, big incision down the middle, his kneecap is pushed off the side. This is his medial side, which is somewhat normal, and this is his lateral side, which is completely destroyed, flat, no cartilage, bone osteophytes forming. So we take a saw and we make a big block cut. We take out that whole medial femoral condyle. Here is what we took out on the right. This is our fresh graft on the left. This is with it's inserted. There's the line there. We've got one screw holding it in for now. And this is his post-op x-ray. We can see now a nice joint surface, nice and round surface, small plate and screws holding it in place until it grows in. And he is now actually about 8 years out. And it's his left leg there. So his life is completely changed with this. He's able to walk, work, has a great range of motion. Now, I have to admit, they don't all work out like that, but some of them do great. Other ones, you know, sometimes the bone doesn't absorb or gets too absorbed and has to be redone. So our ongoing research is to vitrify this cartilage, and we're getting very close to being able to do whole joints or partial joints. We're able to do it on pigs, and we've now done 2 pig transplant studies, which we're in the final stages. This is in the pig. We take a core out, and then we have vitrified bone and cartilage grafts stored, some up to 18 months, and we're comparing them to fresh grafts that are stored for 2 to 3 weeks. And this is just with a graft inserted into that hole. And our early results are looking very similar to the previous pig study that I mentioned, where the vitrified and the fresh look very similar, which again is our gold standard, would be the fresh. So if we can prove that the vitrified perform just as well as the fresh in a 6-month pig study, then we should be able to translate that into humans. In our research, the CTC supplies this tissues from consented donors for research, so that we can confirm that our process that we work out with the pigs works in humans. And then, as I said, once we publish the papers, we'll move forward to integrate this into the tissue banks as well. These are my primary research collaborators right now with regards to this type of research. And obviously, this requires lots of funding over many, many years from many sources and lots of people to help out. And that's my talk.
Corinne Marceau is a certified tissue banking specialist from the Comprehensive Tissue Center. She has a master's in biological anthropology from the University of Alberta and taught anthropology and anatomy at Porter College for over 10 years. She is the surgical bone program lead at CTC and has worked in tissue donation for 14 years. So go ahead, Corinne.
Thank you, Janet. So today I'm just going to talk about some recent developments in changes in legislation and regulations here at the CTC and how that impacts tissue donation in Alberta. So I have no conflicts of interest to declare. Today, I'll just be talking a little bit about Bill 205 and the change in legislation to the Human Organ and Tissue Donation Act and what that means for tissue donation throughout Alberta. We'll talk a little bit more about changing ATB regulations surrounding tuberculosis screening that are currently affecting our donor numbers. And I'll give an update about changing demands in tissues that are being requested for transplantation. The Comprehensive Tissue Center was established in 1992. It started as a skin and eye bank and then expanded as demands for different types of tissues increased. We're located in the Aberhart building, and our operating room is located in the University of Alberta Hospital. We are the second largest tissue bank in Canada that is comprehensive, meaning that we recover, process, and distribute human tissues for transplant within our facility, and we're second only to Nova Scotia. So we provide tissue to a variety of research groups if the tissue is not suitable for transplant, as you just heard from Dr. Jomha, including things like tissue for research on cartilage. We have 9 tissue specialists available 24/7, and we can be paged anytime. So the tissues that can be donated, many of you may already be familiar. Eyes can be donated for the purpose of cornea and sclera transplantation, starting at the age of 2, depending on whether there are recipients waiting for those smaller sizes. Skin can be used for severe burn victims and processed into skin grafts. Heart valves are another tissue that can be donated. Bone and tendons, costal cartilage up to age of 40. And we do have 2 living donor programs here at CTC. So our surgical bone donor program, where we ask patients who are going for a hip surgery if we can have the femoral head that is normally removed during that surgery. And amniotic membrane, which is where we go to planned C-sections, scheduled C-sections at the Ms. and Grey Nuns, and recover the placenta, and then we take it back and process it into amniotic membrane. So we are heavily regulated and audited by both Health Canada and the American Association of Tissue Banks. And I'll talk a little bit more about that in a moment. But first, let's talk about some changes in legislation. The Alberta Organ and Tissue Donation Registry was established in 2014 with the Human Organ and Tissue Donation Act in Alberta. The registry allows people to register their intents regarding organ and tissue transplantation, tissue donation for transplant, research, or medical education, or whole body donation. And if you have registered your intents at a provincial registry, then a little heart with the word donor will appear on your driver's license. Now, recently, that Human Organ and Tissue Donation Act was amended with Bill 205. So starting April 1st of this year, the language of the act that stated mandatory consideration for organ and tissue donation, that language changed to mandatory referral to an organ or tissue donation program. So any medical practitioner making a determination of death or who has a patient in their care who is approaching death was previously required to consider organ and tissue donation. They are now required to refer and provide that information to a donation organization, or if the physician or the nurse practitioner has deemed that patient ineligible for organ or tissue donation, they are required legally to make a note of the reasons in that patient's chart. So in practice, this is currently something that's being done in the Edmonton area by nurses. So although the medical practitioner, generally the physician would be the one filling out the death certificate, it is in practice the nurses who are referring to us as a tissue donation organization. That works a little bit differently for HOPE for the organ donation program, but for our purposes, we are currently in-servicing the ICUs and ERs throughout Edmonton that are the ones who are typically referring tissue donors to us. And that plan now is to expand that in-servicing to set up tissue donation referrals for any patient that passes away to the rest of the hospitals in the province. Most deaths can be referred and considered for tissue donation. Our criteria is based on cardiac death, not brain death, like in the case of organ donation. So currently at the Comprehensive Tissue Center, we have a direct approach system where we have an agreement with ERs and ICUs at all of the major hospitals in the Edmonton zone and the greater Edmonton area to refer every death to us and to kind of do an initial screening with what we call a referral information form. So we also get referrals from HOPE, from physicians and nurses, or from family who are aware of the donor's wishes, or sometimes from the medical examiner's office. So in Edmonton, at the CTC, it's the tissue specialist who performs the Connect Care screening, checks the donation registry to see if there are donation intents for that patient. We are the ones who conduct the medical and social history questionnaire and consent with the next of kin. We're the ones who do the recovery and the processing. We're also the ones who review the patient chart to determine eligibility. So some common deferral reasons include infectious diseases, including COVID-19, certain neurological disorders of unknown cause, high-risk behavior, and hemodilution, which is where the patient has been given too many blood products for us to reliably test the blood for transmissible diseases. Many chronic conditions do not preclude donation, and we do have a very successful palliative donation program where we actually approach patients with a diagnosis that are in palliative care to see if they would like to consent on their own behalf for tissue donation. We do a physical inspection at the time of recovery for any signs of high-risk behavior, pathology, active infection, or other medical contraindications that we may have missed in the screening and chart review. So basically, our direct approach system has a tissue donor referral form that screens out these automatic deferral reasons: age greater than 80 years, active systemic infection or sepsis, infectious or transmissible diseases such as HIV, hepatitis B or C, leukemia, lymphoma, or myeloma. Most other types of cancer are acceptable for at least cornea donation, even if it's a current condition, and neurological disorders such as MS, ALS, dementia, or Parkinson's. Now, this brings us to our AATB criteria, or screening criteria. So although we have these kind of basic automatic deferral reasons, we have pages and pages of other deferral criteria that we need to screen during the screening, consent and questionnaire process, and the chart review. So we now have some new screening requirements as of September 4th from the AATB, and some of you may have noticed that the age criteria for the tissues that we're currently taking have changed, such as skin and bone and tendon. So skin, we previously were recovering up to 80 years of age. Now that's down to 65. And some types of bone previously was up to 70 years of age, and that has now changed down to 65 as well, and I'll tell you why. In May 2021, there was a tuberculosis outbreak in Delaware linked to contaminated bone graft products from an American tissue bank containing live cells used in spinal surgeries between March and April of 2021. So latent tuberculosis infection is estimated to affect about 25% of the world's population and about 4 to 5% of the American population. Tuberculosis, it's actually a bit higher here in Canada. And this TB transmission via bone graft was previously only reported once in 1953, and there was only one known case of TB transmission via a heart valve in 1976. So this was a previously unknown kind of a transmission. In this case, an 80-year-old male deceased tissue donor had some unrecognized risk factors, symptoms, and signs that were consistent with tuberculosis. Just to give you a bit of background on the patient, he did have end-stage renal disease. He was admitted to hospital after a few weeks of shortness of breath, cough. He developed an elevated white blood cell count, evolving bilateral airspace opacities and pleural effusions. He developed acute liver failure during the course of his admission to the hospital. His blood cultures were negative, and his cause of death was attributed to cardiogenic shock and presumed hypoxic brain injury after a cardiac arrest during his admission. Now, there were all kinds of potential unrecognized risk factors and symptoms that would have led us not to take him as a bone donor. Also, he was 80 years of age. Our limit at the time for bone product or for any bone products would have been 70 years of age. So we would not have taken this patient as a tissue donor as part of our screening and criteria. So during the questionnaire, there was some unexplained weight loss. The donor had had a negative tuberculin skin test 4 months prior and had answered no to all of the screening questions on the TB risk assessment questionnaire. So this is something that was missed during the questionnaire by the proxy as well. There was no known exposure to tuberculosis. So for this particular donor, long bones were recovered from the upper and lower extremities, as well as the pelvis, and they were processed into demineralized cortical bone and viable bone matrix allograft products. So there were 154 separate units of these products containing live cells that were distributed to 37 surgical centers in 20 different states in the US. So 113 of these recipients between the ages of 24 and 87, that all but one who were having spinal surgery received these products. 12 were immunocompromised. 87 of these recipients developed evidence of tuberculosis either through the lab or imaging. 8 patients died, although only 3 were confirmed to have for sure died of tuberculosis. 55 of these patients were readmitted for tuberculosis to the hospital, and 48 underwent additional surgical procedures for complications, including abscesses in the spine, osteomyelitis, discitis, and evidence of bloodborne dissemination, including pulmonary lesions, pulmonary as well as CNS tuberculosis. There were some brain tuberculomas and 1 spinal cord that was also affected. In addition, 73 healthcare professionals developed new latent tuberculosis infection following exposure to the contaminated product, the recipients, the surgical instruments, or the medical of waste. So during the surgery, the suctioning, the drilling, the wound irrigation, and then following that, the decontamination of instruments, and then the post-surgical care for these patients. And the patient care once they were readmitted for tuberculosis caused all of these exposures for a healthcare professional, and then nearly 6,000 exposures through the contacts of the healthcare staff as well as the patients. So with those nearly 6,000 exposures, an additional 33 contacts also developed latent tuberculosis infection. And that's a rate of 1.5%, which is not so bad, it's less than what would be expected due to a tuberculosis exposure because the effect was mediated by continuous masking in place because this happened during a pandemic. This has resulted in some recommendations from the AATB. So we already did ask about previous tuberculosis in our questionnaire. These questions have become a bit more detailed, and we're asking some more stringent questions about tuberculosis. So AATB has recommended screening out any individuals with any history of active tuberculosis and any individuals with a history of latent tuberculosis infection within the past 2 years, or any positive TB test, including a skin test. This is the same as is being recommended for the IBank Association of America as well. So it's applying to eye tissue as well. The exclusionary criteria that AATB has recommended, in addition to this, is for tissues containing viable cells. So that would be any of the tissues such as minimally processed tissues or tissues processed in a manner to maintain viable cells. And these additional criteria are any exposure to an individual with tuberculosis in the past 2 years, latent tuberculosis infection greater than 2 years ago, age greater than 65, chronic renal failure on dialysis, and solid organ transplant recipient. So these are now deferral criteria that we have to apply to any patient that is donating tissues that could be described as having viable cells. And that is assumed to be all tissues unless we prove otherwise. Other risk factors that must be considered by the medical director in accordance with the clinical picture and the rest of the history are birth, birth in, travel to, or residence in a country for greater than 3 months cumulative at any time, with a tuberculosis incidence of greater than 20 per 100,000 population. And of note that 20 per 100,000 is lower than the threshold that the WHO has to consider a country as a high burden country for tuberculosis. In addition, we must consult our medical director for any history of homelessness, residence or employment in a shelter that houses persons experiencing homelessness, or a long-term care facility. So any residence or employment in a long-term care facility, incarceration or employment in a jail or prison, diabetes mellitus, alcoholic liver disease or cirrhosis, and use of immunosuppressive drugs. So all of those factors need to be now considered by our medical director as a potential risk for tuberculosis. As I mentioned, the Eye Bank Association of America has a bit of a different take on this. They're considering those first two criteria as deferrals because of the increased risk of tuberculosis, but they have decided that the risk of including donors over the age of 65 as a deferral criteria is is unreasonable. So that risk is considered to be minimal because there have been no reports to date of tuberculosis transmission via ocular tissue transplantation. And in addition, they've used as a justification that due to the large number of ocular tissue donors over 65, such a restriction would place an undue strain on the donor supply for eye donors, which is our source of corneas. Currently, the only commercially available test is in the US is approved for sputum only. And so that is something that would have to be adapted and validated for other uses if we were to try and screen additional tissues for tuberculosis. And so this has greatly affected our donor supply for minimally processed tissues, such as surgical bone, because the surgical bone is recovered and just placed in storage at minus 80 degrees for a period of up to 5 years. It is considered to contain viable cells. And so that is tissue that we don't process before sending out for transplant. And so we do have now a hard age limit of 65. And you can understand that a lot of patients going for hip surgery are over the age of 65. So we are doing a validation of our processing protocol for cancellous products, including ground cancellous and cancellous chips, to try and ensure that they are devoid of viable cells. So we currently have a 7-step bone washing protocol as part of that processing, including rinsing with hydrogen peroxide. And so we are doing a 2-part study where we assess the cell viability in those wash samples after each step at the flow cytometry facility. And then we're going to analyze the final cancellous product at the cell imaging center to see if there are any viable cells left after that processing. Currently, we're optimizing the testing procedures and a trial run assessing the wash samples to optimize our study protocols. The preliminary results do show that we don't have viable cells, so the hope is that we can release those non-structural bone products that we have still in our freezers from donors between the ages of 65 and 70. And the hope is that we can continue taking those products from donors between 65 and 70 in the future, because that is our largest source for these cancellous products, which are in very high demand. This is just an image of the ground cancellous prior to the washing procedure and post-washing procedure. I'll just talk briefly about costal cartilage. This is another tissue that has increased in demand, and we're not keeping up with demand currently for these tissues. So we have increased our distribution of costal cartilage from 29 pieces in 2021 to 54 pieces in 2022, and that demand is still increasing, and we, as I mentioned, don't have enough in quarantine or in release to meet that demand. So this costal cartilage is recovered after the heart while the chest is still open and sterile, and they're used in things like septorhinoplasty, ear reconstruction, and other kind of cosmetic surgeries. And then, as Dr. Jomha mentioned, we have these fresh osteochondral allografts. The types that we recover are the talus, the distal tibia, the femoral, either the medial or the lateral femoral condyle, the patella bone, the first metatarsal head, although we haven't sent either of those out this year, and also the medial or lateral tibial plateau with meniscus. So these are specifically recovered upon surgeon request. They are stored in an enriched medium with antibiotics for up to 14 days. We do take a soft tissue, a bone, and a storage media and rinse media sample for microtesting. And then we perform an assessment, obtain some measurements, provide those to the surgeon, and then we fill out a form for exceptional distribution based on tissue utility. And that includes a review of the preliminary bacterial and mycology results. And then we do a final rinse and confirm the measurements prior to distribution. So this is an image of the fresh talus. And then here I have an image of the femoral condyle, both lateral and the medial. So I have a little bit different numbers than Dr. Jomha, but his might be more up to date than mine. So in 2022, we sent out 4 fresh osteochondral allograft, and in 2023, it looks like we have sent out 7 already. Just some stats from the Comprehensive Tissue Center. One full donor can help over 60 people, depending on the types of products that are processed and how many can be sent out to surgeons for transplant. In 2022, we had 100 donors. That was down a little bit from 2021 when we had 108, but we did have a 24% increase in MS donors, which are musculoskeletal bone and tendon donors since 2021. So that increases the workload for us tissue specialists for each donor. We had 28 living donors. We had 477 referrals and 429 family approaches. And we distributed 3,320 tissues in 2022, which was a 31% increase since 2021. And we're on track to distribute over 3,000 tissues again this year. So the hope is that the new legislation will encourage a culture of tissue donation, increase the number of tissue donors, increase the number of tissue donor referrals, expand that system throughout the province, so that we can meet the needs of surgeons and transplant recipients.
Yeah, hi. Thank you. Great presentation, Dr. Jomha. Very interesting things that you're doing there. I was curious, and I apologize if I missed that because I wasn't able to attend the full presentation. Are you checking for HLA or swine LA, whatever that's being called, before and after your procedure? And does that play a role at all in kind of sustainability of your grafts once you implant them?
That's a good question. They're not checked. So the cartilage itself is considered to be immune privileged. The bone, I believe, sometimes we do have graft failure due to, it's not really well worked out, but most likely due to inflammatory reaction, which could be related to mismatch and too aggressive of it. We want a little inflammatory reaction so that we get the host bone to grow into the donor bone and replace it, called creeping substitution. But with the time frames using fresh grafts, I don't think it's possible. I mean, we're having a hard enough time matching for size and getting them done in time. And if we were to do the HLA matching, I think to find an appropriate donor would be very, very difficult. So right now, it's not being done. It's one of the things that I think we could look into if we do start vitrifying and having bank tissue that you can store for months or years. Then you can have like a large selection of grafts to pick from, and then perhaps get a better match. So I think it's something that we should be looking into at some point, but right now we're not.
I was mostly thinking around HLA expression on your cartilage, you know, like if your process maybe improves that, because that's one of the things we do with our tissue that is used for vascular reconstruction, that they get decellularized in order to prevent HLA sensitization. But you need the living chondrocytes, I guess, so you wouldn't be able to deplete them. But it would be interesting to see if your processing actually changes anything on the HLA expression on the graft, and whether that changes sustainability after you implant them.
So, you know, the cells within the matrix are considered immune privileged, meaning not because there's no blood supply, and the matrix is too dense for any immunoglobulins to get into them. The current thought is that they are not exposed, and so the typing won't really affect the chondrocytes themselves. Perhaps maybe when the cartilage starts to break down over time, then yes, that could be an issue, right? Because then those cells become exposed to the surface. But intact cartilage is supposedly not an issue. In the bone that you transplanted, I think it could be, but we try to wash all of those out. And we try to we do some pulse lavage of the bone to try to get any of the cellular material out right before we implant them.
Okay, thank you. I don't see another hand up, but I see a question in the chat. Andrew, did you want me to read it, or did you want to talk?
Yeah, thanks for the stupendous presentation. It was fascinating. The results, the images, the impact of such research is well received and well felt by heart in these vulnerable patients, for sure. I was curious about the aging, you know, senescence. This has been a very interesting topic for my research for like 6-7 years now. Would this affect the outcomes? Have you found any difference, even by observation or eyeballing of the implanted joints in 6 matched patients? If the donor is above the average of age, would this, for example, make it worse for the outcomes, make the recovery longer, make you know comeback of the disease after healing? Would aging affect the outcomes? And thank you very much.
That's a very good question. And what we've noticed more so in the lab is that donors, as they age, the chondrocytes are much less resistant to stress, and they die much easier. And so we've restricted our parameters to try to keep the donors under 40 years of age. And it's a bit of an arbitrary number. In our research, it's we notice, like when we get donors that are in their 50s and 60s, that our process does not work nearly as well. The cells don't survive nearly as well. From a clinical perspective, it's much harder. We don't have enough numbers. We don't really have all of those details. So I can't really give you an answer to that from experience. But my expectation, based on what I see in the lab, is the younger the donor, the more likely you're going to have a good result. And I do my best to try to keep all the donors under 40 for the fresh transplantation.
Thank you very much, Dr. Jomha. We have been working on some xenotherapeutics recently. This might be a great extension for your fascinating research to intervene and inject such, you know, translational therapeutics later on, so that you're shooting 2 birds with 1 stone. You're implanting the joint, then keep it up in shape, protected from senescence. But thank you very much. I appreciate it.
Very interesting.
Thank you.
And the next question I see is from Donna for Corinne, I think. Donna, did you want me to read your question, or did you want to ask? not hearing from Donna, I'll just read this question. The question for Corinne is, I take it that we Canadians follow the American protocols as they are global standards. She's
Yes.
thinking of the CTC protocols mentioned by you.
Yeah, good question. I mean, we voluntarily are a member of the American Association of Tissue Banks, and they're the ones who do our regular audits. It's not required for a tissue bank in Canada, but it would be very difficult to have our tissues accepted for transplantation by surgeons if we weren't certified by the AATB. So it does not apply to ocular tissues, but does apply to our other tissues, and it is the global standard.
Okay, thank you, Corinne. I see that Linda has 2 questions, and one of her questions in the chat was, can tissue donation, ocular or other tissue, occur after a palliative patient death in hospice rather than hospital? And Corinne answered in the chat, yes, Linda, tissue donation can occur after a palliative patient death in hospice, even in the home. So that's good for us to know. And Linda had another question for Nadr Jomha. Did you want to ask your question, Linda, or do you want me to read it?
Sure, I'll ask it. Just wondering if what the indications are for choosing a tissue allograft over a total joint replacement for an ankle. Does it depend on the extent of damage, or what are the indications there?
So ankle replacements are a reasonable operation, but they have significant limitations. Typically, a patient needs to be older, less active, have good bone stock, and have good range of motion. So most of our allografts in the ankle are done on younger patients with more focal defects as opposed to a global arthritis. So a patient that's looking for either an ankle fusion or ankle arthroplasty is at older, any age for the fusion, but older for the arthroplasty or the replacement, and more global disease. And if we have a more focal defect, then we can go more aggressive with the osteochondral transplant. It is a pretty big procedure. Quite often we have to do an osteotomy and break off the medial malleolus or a portion of the tibia to gain access to the talus because it's quite confined. And it also, there's 2 other joint surfaces, the talonavicular joint and the subtalar joint underneath, that we don't really address with osteochondral transplants at this time. It's mainly the talar dome. So I would say focal defect, we would be more aggressive to do an osteochondral, especially in a younger patient. As we get older, then we're going to look more to the replacement or the fusion.
Thank you. Terrific presentations to both of you.
Thank you.